Today is the second part where we look at the cardiovascular morbidities and their perioperative management. We'll look at one by one from commonest to the rarest. Right. So first and foremost, hypertension that we all come across. So obviously, anyone who is undergoing any surgery with uncontrolled hypertension is likely to have slightly higher complications around the perioperative period. But usually, the point I want to make from this slide is anyone who is having elevated BP but it is less than 180 by 110 and without any other RCRA risk factors associated, he might just undergo surgery without any further elevated risks. I may
almost more than 50% of time sympathetic overactivity and anxiety.
And just as I mentioned, you might use ABPM to distinguish between that situational hypertension. If the time allows,
it is very difficult to anxiety factor how can you alleviate? જ્યાં સુધી ઓપરેશન ના થાય તો તે એન્ઝાઇટી તો જવાની જ નથી. અને see I have seen કે પેલો patient BP 160-100 હોય, moment that patient is taken on the operation table, it is 200 by 120.
Of course.
And the surgeon say કે I cannot operate.
એટલા માટે જ maybe elevated છે પણ less than 180 110 છે, so you may leave it up to anesthetist કે manage કરશે on the table. And there should not be any grave risk of complications.
The cardiologist, do you advise કે આ બધાને પહેલા તો ECMO આપતું હતું?
ECMO short acting.
એ આપતું હતું. Do you advise કે આવા બધા પેશન્ટને ECMO આપવું જોઈએ? It is ultimately beta block. That will reduce the sympathetic activity. After that,
ECMO is like it's during the procedure part of it. ECMO is short acting IV, so it's like for the like anesthetist part of it.
But that is what I am asking you. During surgery, will you advise કે આ blood pressure up છે? So will you advise કે ECMO આપી દો?
RCR is a reverse cardiac risk index. આપણે last time check one જોઈલા કે any history of cardiac disease, heart failure evident present છે કે બીજી morbidities. એ બધા factors ના હોય ને આટલું BP હોય તો it's okay.
Majority of time, almost all major surgery patient is given alprazolam night before surgery or in its tranquilizer. In spite of that, જો આ blood pressure આવે પછી આ બધું લાગુ પડે કે જે સ્ટ્રેસ હોય પહેલેથી કિલ કરી દીધેલો.
Yes. So the chronic hypertension treatment has to be continued unless otherwise during the perioperative periods, and of course short acting oral and IV antihypertensive medications can be used. Beta blockers, if their patient is taking chronically, it should continue. Clonidine, of course, should be continued to prevent rebound hypertension. ACE inhibitors and ARBs can be put on hold during the perioperative period. That's again, we'll see in the guidelines, it's a very mild recommendation, that's class 2B kind of.
Previously it was said કે AC ને અભી બંધ કરી દો, પણ nowadays with due precaution.
Sir, in this slide છે ને guideline વાળી એની અંદર મેન્શન કર્યું છે કે ભાઈ લો નોર્મલ હાઇપરટેન્શન વાળા હોય એની સાથે 100 110 BP સાથે આવતું હોય તો you might put it on hold 24 hours before the surgery, and that is again a weak recommendation. જરૂરી નથી, compulsory નથી. If you feel like કે ભાઈ આ લો સાઇડ પર છે ability with that. અને again એ બધું તમે RAS inhibitors are if you are going for heart failure, then again the guidelines says કે A indication હોય then you should continue it. Intraoperative hypertension. First try to maintain your MAP above 65 systolic BP over 90 mmHg, and those below 15 minutes are likely to cause any cardiovascular damage. That was an IMPRESS trial. We will see again in the current slides. And the current recommendations in the guideline are to maintain MAP above 65 or systolic BP over 90 during the surgery. That was the trial, and patient with a certain risk factor undergoing 3 surgeries, and either they had a tailored BP target with target BP being within the 10% of their systolic BP, and those who had maintained in that range, they had a little bit less complications, perioperative target of was less in those patients. post-operative part, again, the post-operative part, the persistent probability is likely to cause any cardiovascular or any other target organ damages, and that can be managed with IV fluids or vasoactive drugs easily. Again, the hypertension post-operative phase, first of all, look at the transient acute triggers for that pain, anxiety, and etc. And try to control it with the short-term medications. Now, these are the long-term considerations for the hypertension patients. The key point is that have a delayed BP management, try to maintain MAP around time, whatever you mentioned, about 65, this will be below 90. Most important thing is that in post-operative hypertensive patients, do not overburden them with the medications at the time of discharge only to prevent any reactions with the enhanced effect with the any other enzyme medications. So these are the recommendations as per the guidelines. Again, first recommendations, go with patient is taking any chronic antihypertensive drugs, please go ahead and do the surgery with the drug continue. Elevated risk surgery with the cardiac risk factors, you may defer the surgery if the systolic BP is above 180 and diastolic BP is above 110. That's again a very weak recommendation, but if your patient is like this, surgery emergency nothing, BP admission to one risk factor, then you might say, okay, then defer your surgery. Intraoperative blood pressure, as I mentioned, try to maintain MAP over 65 and systolic BP over 90, and post-operative part, try to control post-operative immediate hypertension with use of intravascular volume or the inotropic drugs. Second, most common entity that you will come across in the pre-operative patient is the coronary artery disease, and of course, any patient with coronary artery disease is going to have slightly higher risk of MACE during the perioperative period as that of the normal patient. But the thing is that the type of the surgery as well as the type of coronary artery disease, whether it's an acute coronary syndrome or it's a chronic coronary syndrome, defines the management part as well as the risk part to a large extent. These are the recommendations for revascularizations. Okay, we are discussing this for non-emergent surgery.
Please go to previous slide. The risk multiplier, history of myocardial infarction increases the perioperative MACE risk by 3.5 fold, right? So this history in what period time? Within 6 months, within 1 year, or any history in lifetime of MI will increase the risk?
Any history, sir, any history. RCRI will have that big marker.
Is it a non-specific thing? Is it you are talking about non-HT elevation MI, HT elevation MI?
That has not been mentioned.
LVEF after MI was normal, mid-range, EPD.
Maybe the details, but they have not mentioned. But if you look at the RCRI index, there is one parameter called it's a known case of ischemic heart disease.
So suppose someone is having MI at 42 years of age, who is undergoing some major abdominal surgery at 65 years age, then the risk is 3.5 times higher.
Theoretically, risk of MACE is 3.5 times.
If you calculate ના તમે calculate કરેલા છે તેવું તમે history મૂકો ને એટલે risk 10 to 15% આવી જાય. This to risk એનો moment આ તાકમાં
that is the best part of
આવા બધા patient ને હું એ સ્કોર માં લગાવ ને સીધો આટલી history તમે એડ કરો ને the risk more than 10 to 15% આવે.
Either it's a known ischemic anivascular disease, cardiovascular or serious.
Even CABD કરી હોય stent મૂક્યો હોય બધા આ તમે મૂકો ને એટલે risk 10 થી 15% આવી જ જાય.
And the second most important is airway dysfunction કે ભાઈ patient ને heart failure ની history છે કે નહીં, પછી diabetic if it is on insulin અને CKD patient, those are the main risk factors in index. So revascularization guidelines. Again, this all is being discussed in case of a non-emergent surgery where postponing the surgery is not immediate threat to life or limb. Otherwise, you go ahead and do the surgery regardless of whatever the cardiovascular issue is that we showed last time. So if it's an ACS, then you might defer the non-emergent non-cardiac surgery and go ahead with the ACS management. For chronic coronary disease, if the disease is left main with more than 50% of stenosis, you might just defer the surgery and manage the left main stenosis first and then go into the surgery. Non-left main chronic coronary disease undergoing mild or moderate risk cardiovascular surgeries, there is no benefit provided to the prophylactic revascularization to the patients.
આ જે બધા ક્રાઇટેરિયા છે ને to be frank with you,
Right.
when you are giving general anesthesia, it matters.
Okay.
When you give spinal anesthesia or regional anesthesia, that's why I raised the question કે આ બધા જે ક્રાઇટેરિયા છે ને
એટલે સર એ લોકોએ મોસ્ટલી આવા બધા જે સ્ટેટમેન્ટ્સ આપે છે ને ત્યાં તે અહીંયા નથી મેન્શન કર્યું, અધરવાઇઝ they have mentioned it's a low risk non emergent cardiac surgery હોય તો તમે પ્રોવાઈડ કરી શકો, લો રિસ્ક સર્જરીઝ હોય તો પ્રોવાઈડ કરી શકો, મોડરેટ રિસ્ક ઓર હાઈ રિસ્ક કાર્ડિયોવાસ્ક્યુલર સર્જરી હોય તો બધી જગ્યાએ આપણે વર્ડ યુઝ કરે છે કે ટેક અ મલ્ટી ડિસિપ્લિનરી ડિસિઝન કે સર્જન કાર્ડિયોવાસ્ક્યુલર પેશન્ટ બધા ભેગા થઈને ડિસાઇડ કરે ફોર એની મોડરેટ ટુ હાઈ રિસ્ક પ્રોસિજર વેધર ઇટ્સ acute or chronic. And
the moment any person more than 45 years comes, nowadays કોઈ ને કોઈ કોમોર્બિડિટીઝ હોય, કોઈ ને કોઈ તો ઇશ્યુઝ હોય છે, એટલે થાય શું છે આ બધા જે ગાઈડલાઈન છે ને એ બધામાં બેસાડવા બેસું ને તો ઓપરેશન થાય જ નથી.
of course ઇનફેક્ટ આ ગાઈડલાઇન્સ થોડું ઓપરેટિવ પ્રોસિજર હેસલ કરી દે છે કે ભાઈ not undergo revascularization if you are trying for a low risk surgery and it's a chronic non left main cardiovascular disease. એટલે કોઈ પેશન્ટ આવે તમે ટીએમટી કરાવે પોઝિટિવ છે અને નોન ઇમર્જન્ટ લો મોડરેટ રિસ્ક કાર્ડિયોવાસ્ક્યુલર સર્જરી છે, ઓકે પેશન્ટ is being toxic કે ભાઈ નહીં મારા જે સ્કેનર સિસ્ટમ you go for an invasive coronary angiography that is also not routinely recommended but you go ahead and do it and you find it's a non left main coronary artery disease and the patient પૂછે કે ભાઈ હું આ પહેલા કરાવું તો you may say કે it's not very likely to benefit but again choice can be made with entire team.
The risk of major surgery, the stress of major surgery is equivalent to how many ABDs?
The exact figure I don't use, but I will.
Must be moderate to severe, 6-7 ઉપર હશે.
એટલે most of the time when valvular lesions આવશે ને ત્યાં બી એમણે જે બેચ કેટેગરીમાં ક્લિયર કટ કીધું છે કે સિવિયર સિમ્પ્ટોમેટિક valvular lesion હોય અને નોન ઇમર્જન્ટ સર્જરી હોય તો પહેલા વાયર ટ્રીટ કરવાનો પછી સર્જરી કરો અને એસિમ્પ્ટોમેટિક ઓર નોન સિવિયર valvular lesions હોય તો પહેલા સર્જરી કરો. Anything in between they have mentioned કે ભાઈ બધા ભેગા થઈને ડિસિઝન લો.
But that asymptomatic term is very tricky because valvular patient તમારી OPD માં might come as a asymptomatic patient, but you will make them exercise and you will realize that the lesion is significant.
Of course.
Right? So asymptomatic declare કરતા પહેલા stress test હોવું જરૂરી છે. રૂટીન એક્ટિવિટી એની ઘણીવાર અનેક કસ્ટમ એક્ટિવિટીમાં એ બ્રેથલેસ થઈ જતો પણ રૂટીનમાં ના થતો હોય છે એમાં છે 2-3 વાળા છે they are always a googly.
Yes,
they can go anywhere.
Of course activity limit કરીને they become
Exactly. So એ તો કોઈ દી આપણે ઘરે તો જોવાના જ જોવાના, right? So we need to make them exercise or at least some sort of stress testing. It's absolutely matter. આમાં જે આમાં તો લાસ્ટ સ્લાઇડ હતો પાછળવાળી જે છે બહુ અઘરી હતી. ઓલી જે એમાં જે હજી એક પેલું ના ટેબલ હતું ને હા એમાં જે થર્ડ વાળું છે બરોબર છે કે જેમાં એક પેશન્ટ વિથ નોન લેફ્ટ મેઇન CAD who are planned for NCS. So now LAD ને LCX માં 80% બ્લોક આવ્યો હોય somehow અને બાકી બધી કોરોનરીઝ ફાઇન છે તો you will consider this is non left main
coronary.
Right, so treating that 80 or 90% of block will not improve any mass in non-cardiac surgery.
Theoretically, by means of evidence, by means of trials, routinely it should not provide any additional benefit. But again,
હવે આ વસ્તુને
the guidelines
ક્લિનિકલ પ્રેક્ટિસમાં એક્સ્ટ્રાપોલેટ કરીએ ને કે આપણું સગું કોઈ આવ્યું છે અને લીવર કે ગોલબ્લેડર કે પેન્ક્રિયાસ કે ઇન્ટેસ્ટાઇન ઓપરેટ કરવાનું છે અને somehow we came to know સિટી કોરોનરી કે ઇન્ટરનેશનલ કોરોનરીમાં કે 80-90% LAD બ્લોક છે અને તમે એવું કહો ને ના સ્ટેન્ટની જરૂર નથી પહેલા પેટની સર્જરી કરી લો તો કેટલા લેવલે બોમ્બ ફૂટે ને એની કોઈ કલ્પના જ ના કરી શકે.
No, guidelines are not brahmavakas. They are just to guide us. Situational decisions can always.
હવે એવી 2A 2B લખ્યો ને તો તમારા શબ્દ આ તો 3 માં લખી દીધું કે બેનિફિટ જ નથી તમે ગમે તે કરો.
But again, I want to highlight that these guidelines are made by US.
So આમાં ના I'll tell you ના it's not about US or India. The block is there, stress induced myocardial ischemia છે કે નહીં જોવું જ પડે. આમાં કદાચ ક્યાંક તમે મેન્શન નથી થયેલું.
નહીં, where it might differ is for a US chronic CCD patient and the appointment touch at the 12 minutes they'll get for revascularization because they are getting echo appointments at 2.5
50% block, you have to check by stress-induced myocardial. આમાં એક મેન્શન ક્યાંક હશે આના ડિસ્ક્રિપ્શનમાં ટેબલની નીચે. આમાં તમારા પોઈન્ટ્સમાં નથી.
એમને ખાલી એક જ ટ્રાયલ મેન્શન કરી છે એની નીચે, અને that trial will see the conclusion part, you know. But as like guidelines are just to give us a brief idea, they are not completely
generic ને નોન સ્પેસિફિક સ્ટેટમેન્ટ છે. આપણે તો સ્પેશિયાલિસ્ટ માણસો છીએ ને, કંઈક થોડું વધારે સારી રીતે ડિસ્કસ કરશું, પણ આનું હશે આનું ડિસ્ક્રિપ્શન થોડું વધારે હતું.
ના, એમને they have clearly mentioned just left main and non left main. એની અંદર પછી LAD, proximal, क्या कहते हैं, coronary anatomy, ये બધું they have not mentioned. Honestly, in the entire guideline.
ચાલો હવે તમે કીધું તો આપણે માની લીધું.
But
ઇમ્પ્લિમેન્ટ કરતા પહેલા તમારું જજમેન્ટ લો.
હોય જ ને સાહેબ.
ગાઈડલાઇન્સ are guidelines.
You have to subject this fellow for stress testing.
okay. That was the trial that they have mentioned. So coronary artery trial, coronary artery respiration before elective major vascular surgery. We will just look at the conclusion. And
કયા વર્ષનો ટ્રાયલ હતો એ?
it was 2015 trial.
15.
And 5,000 plus patient, and like surgery type of surgeries were also from mild to high risk, vascular, orthopedic, neurosurgeries. They have all included the large spectrum of surgeries in that trial.
Does not alter long-term survival.
Yeah.
Conclusion. First step.
So even short term data માં પણ કોઈ significant age reduction હતો, and long term was of course not. Depending upon that what was given. Now we underwent revascularization and now it is time for surgery. So what do we do? So if it's a simple POBA or balloon angioplasty, then you might undergo non-coronary surgery after 14 days. If it is DMS, it is safely you can undergo after 30 days. For drug-eluting stent, any major non-cardiac surgery has to be should be postponed for more than 5 months if it's not time-dependent surgery. And for chronic coronary disease, if a gas is implanted and there is a non-immediate non-cardiac surgery or a time-dependent non-cardiac surgery, you might go to surgery after 6 months. In the red part, like the danger part, if a patient who had undergone a gas implantation for ACS undergoing non-emergent non-cardiac surgery in 3 months is likely to cause harm to the patient, so they should be discouraged as far as possible. Again, the same recommendations. The first treatment, if you look at the way, it has to be a multidisciplinary decision from the most point of time, which will include patient, your cardiologist, your physician, your anesthetist, as well as your surgeon, of course. Again, the timing of coronary surgeries after non-cardiac surgeries after PCI, what we have seen in the earlier slide, with the same part. And the perioperative antiplatelet management, that we'll see in coming slides also. If the surgeon is allowing, which is very rare thing, then please continue at least low dose aspirin. After the PCI, the patient is undergoing non-cardiac surgery, and is likely to decrease the MACE or ischemic complications per se. And if the surgery has to be undergone within the 30 days of putting DMS or DS, then please continue with the DAPT unless of course the risk of bleeding is too much. The patient after PCI, if they were on the oral anticoagulant therapy, and if you are going to for the non-cardiac surgery, of course the oral anticoagulant has to be put on hold. But again, if the surgeon is allowing, please continue with the low dose aspirin. That is what the slide needs to say. Intravascular platelet therapy, again, there are no major trials available for it, but the guideline has a big recommendation for intravascular antiplatelets as a bridging therapy, particularly what we use in candidates. And there is a trial that I have mentioned earlier. So, for the antiplatelets, tablets and the medications and the shortest phase of time for which they have to be put on hold. Vascular has the longest period and should be at least put on hold for 10 or 7 days. And the ticagrelor has the shortest time. Again, what is mentioned in the guideline and what is showed the trials are contradictory. That the continuing low dose aspirin puts a patient on at least 1.5 times greater risk of non-serious bleeding, but putting aspirin on the whole is likely to increase the risk of ischemic malaise by 10%. And the meta-analysis are failing to show any benefit with that. That's the point. These are not very important trials. We'll skip that. That was a low dose aspirin trial and it failed to show any benefit with the low dose aspirin, and this was tranexamic acid trial for a non-cardiac surgery patient needing aspirin and bleeding risk, and it didn't show any significant net benefit.
So the first statement I have heard is suppose for patient platelet count is 4 lakhs on the higher side, then the chances of bleeding are less while operating. But suppose that patient is having blood, your platelet count of 1.5 lakh, then the chances of are there 23%. If the platelet count before operation is on the higher side, the chances of bleeding is less.
There is a reason behind it. What? Because if patient is on aspirin, you can say that almost 40% of platelets are inhibited. So suppose the platelet count is 4 lakh, then actual count is 2.5 because 1.6 is inhibited. That is what theory suggests.
Bridging therapy, of course, the granular. The bridge trial was not for non-coronary surgeries, it was for patient undergoing CABG. But it showed slightly, theoretically it showed better platelet inhibitions, but the clinical benefit was hardly comparable. But still you might just use granular for as a bridging agent for a patient who is undergoing non-cardiac surgery after a recent PCI. Third most common entity is the heart failure, and again, heart failure is an added risk to the MACE during the peri-operative period. Ischemic heart failure is likely at a higher risk of complications. In brief, whatever the heart failure medications you are continuing, please continue, but apart from SGLT2, that has to be put on hold at least for 3 to 4 days before the surgery. So these are the recommendations. Class 1 recommendations to put SGLT2 inhibitors on hold at least 4 days before the surgery to prevent non-metabolic acidosis. Rest all the medications, please go ahead and continue. Beta blockers you are taking, please go ahead and continue the beta blockers. These treatments were the part of common guidelines for hypertension as well as for the heart failure part if the patient is taking beta blockers. If somehow you want to start the beta blockers for any patient coming for peri-operative care, you are left with less than 7 days, then you might just hold that decision for a while, because you might not be able to titrate the dose properly, and that might lead to cardiovascular complications. Again, if you are giving any RAS inhibitors as a heart failure therapy, please go ahead and continue those medications. Valvular heart disease, of course, any stenotic valvular disease is going to cause extra risk to the MACE during peri-operative period. What are the recommendations for aortic stenosis? Patient with severe AS who are undergoing surgery, they have to be evaluated for the aortic valve repair or replacement before the surgery. Moderate to severe AS who are undergoing elevated non-cardiac surgery. Of course, echo is everyone who is going to get. But the third statement, again, asymptomatic moderate to severe AS with normal aortic dysfunction. If the echocardiography was done in the past year, 1 year, then you might continue with that report and go ahead with the treatments. Again, these are the associated factors with the AS that you have to consider. Along with the AS, if there is presence of valvular aortic dysfunction, how is the PA pressure, if there is associated coronary artery disease, and the type of the surgery, of course. And as I have mentioned earlier, the decisions are always multidisciplinary towards lot of faculty. asymptomatic AS, severe AS, and the management during non-coronary surgery, non-cardiac surgeries. If these are the low-risk surgeries and the patient has preserved IVF, please, and no severe, no coronary arteries, then please go ahead and do the low-risk surgeries. High-risk surgery, of course, you go for further evaluation as well as the multidisciplinary management protocols now in place. So what do we have as a treatment modalities? AVR, of course. If it is an emergency surgical procedure and if it is at all possible to go for a balloon valvuloplasty, please go ahead and get it done. Asymptomatic severe risk, again, as I mentioned earlier, low risk non-cardiac surgery, preserved IVF, and no absence of coronary artery disease, please go ahead and do the surgery with very less likely risk of death.
So this absence of severe CAD is decided by invasive coronary angiography here?
They have not mentioned it, but of course it will also depend on the patient profile. Bicuspid aortic valve or the rheumatic guy is there. Young age, you are not suspecting. If you look at the routine aortic stenosis or any routine stenotic valvular heart disease, below 40 is less likely to have coronary artery disease. Above 40, any valvular stenotic patients, even for the valvular surgery, we are going for prophylactic coronary artery disease. So it will not depend on the patient profile. The specifics, they have not been given in the guidelines. Of course, the Peri, before the surgery, if you are going for AVR, it is always going to reduce the valvular weakness. And that is the flow chart, and again we'll focus on the extreme right and the left part. Severe symptomatic aortic stenosis, if your patient is undergoing any non-emergent surgery, please go ahead and do the AVR first and then think about the surgery. Severe asymptomatic aortic stenosis, again, as we have mentioned multiple times, with preserved LVEF, and it's a low risk surgery, please go ahead and do the surgery. And it's a moderate risk or high risk surgery, then again the multidisciplinary aspect comes into the picture. Anything in between has to be a multidisciplinary decision whether to treat the valve first or the surgery first. And it will also depend on the type of the surgery and then the need of the surgery, how emergent it is. Mitral stenosis. Again, any valvular heart, known case of valvular heart disease has to undergo proper evaluation before the surgery. Anyone who is having severe MS and cannot be treated before the surgery, please undergo aggressive hemodynamic monitoring. They have recommended for invasive CAT monitoring during the perioperative phase. Beta blockers, continuing beta blockers are likely to be, of course it's a common sense that those who are prescribed for beta blockers or any rate control medications, please continue during the perioperative phase. What are the associated risk factors in an MS patient? Severe MS patient with pulmonary edema or with hypertension encouraging as AF well commons. They are at a slightly higher risk. Please try and control the pH, pulmonary arterial hypertension if possible, and also the blood pH here mentioned. These are the important. Now, if you look at the recurrent lesions, they are better tolerated as compared to the stenotic lesions, and the main risk is heart failure during the surgery. Again, if it's a known case, please undergo and do a complete evaluation using echocardiography TE if necessary to define the severity of recurrent lesions. If the recurrent lesion is symptomatic, severe, and it itself is a indication for valvular management, and if your surgery is non-emergent, then please go ahead and do the valvular management first, and then go ahead with the surgery. So, the second point, that is what I want to mention. If your patient is having moderate to severe MR, but the every systolic function is preserved, EA pressure is below 50, and if it is low or moderate risk surgery, then please go ahead and do the surgery with very low risk of MACE due to MR during that phase. That is the important aspect. And also, please try and avoid preload during the perioperative period and making use of beta blockers.
So this PA pressure is eco-guided, right?
Eco-guided peer pressures. AR recommendations again, the risk are hypertension, arrhythmias, heart failure, pulmonary edema, and death. Again, associated risk factors, LV dysfunction, serial creatinine more than 8%, or it's the surgery itself is the highest surgery. Again, try and avoid any higher preload in that patients. Undergo proper evaluation using routine or TE echocardiography, and for post-operative, please monitor patients hemodynamic carefully and avoid any unnecessary hypertension or hyperhypervolemia to the patients. The patients with moderate to severe valvular regurgitation, perioperative, of course, echocardiography is all we are going to get it done, so no need to discuss that part much. If the regurgent region is itself an indication for valvular intervention, such as severe symptomatic regurgent lesions or severe asymptomatic regurgitant lesions with the LV dysfunctions, if the time permits, please take a multidisciplinary decision and go ahead and treat the valve first if possible. Asymptomatic patient, normal LV dysfunction and PA pressure less than 50% is reasonable to undergo any NCS before the any valvular interventions. Asymptomatic patient with moderate to severe aortic regurgitation with preserved IVF, again reasonable to go for NCS before the valvular interventions. And these days, of course, we come across the patient who are undergoing TAVI and mitral valve, H2H with mitral valve repairs, and these are the guidelines for those patients. Those who are undergoing TAVI, please go ahead and do the cardiac surgery as deemed by the surgeon and have indicated at the time. Same for the mitral valve repair.
What is TEER, transesophageal?
No, H2H repair.
H2H. So it is transcatheter only?
Transcatheter. We don't do that much. Mitral valve is common these days. NSUI annular ring per average, that is also possible with the DCMP severe MR patients. For PH patients, again, that's the another common entity that you come across. For any patient who is on treatment for pulmonary arterial hypertension, please try and continue whatever protein medications he is taking for the PAH. Those who are at severe PAH, please have a cautious hemodynamic assessment, preferably an invasive one, for operative cardiopulmonary complications and management. Same things mentioned in the different slides. The last slide. If you want to add something for pH management, then please try and add inhalational agents, nitroglyceride as well as prostacyclines. That is beneficial during the perioperative period and is likely to definitely. Of course, everyone knows that dilated pH is a risk factor to perioperative period. Too much into that. Inhaled vasodilators are better to start during the perioperative period if new agent has to be added. HOCM is again one common entity. Please continue with your control medications during the perioperative period. Avoid any hypovolemia, avoid any hypertensions, and avoid tachycardias. During the hypovolemia, please first correct it with the IV fluids and do not use any beta agonists as they are likely to cause the LVB obstruction. Instead, please use alpha agonists such as phenylephrine or vasopressin for those patients. And do consider perioperative echocardiography evaluation. Intraoperative also is possible for the better management of that patient. For the congenital heart rate diseases, only will just for intermediate and elevated risk.
So any comment on how we decide intravenous beta blocker kya patient માં આપવાનું LVOT obstruction કેટલું થાય તો આપણને last point હતો previous slide માં. In select cases, what are the select cases? Any comment on this? Okay, hypotension भी થયું છે અને LVOT obstruction भी વધારે છે. So these are very contradicting.
No.
if hypotension develop એમાં 4 પોઈન્ટ આવે છે
જે last point છે ને એમાં
ઇન્ટ્રાવેનસ બીટા બ્લોકર આપો તો હાઇપોટેન્શન કેટલું થશે એવા કયા સિલેક્ટેડ કેસીસ
ગ્રેડિયન્ટ બહુ હાઈ છે બેઝિકલી બીટા બ્લોકર્સ તો તમારું ગ્રેડિયન્ટ ડિફર કરવાનું છે
and below percent hypotension
if it is like again कोई specific guidelines नहीं है it's a borderline hypotension which can be managed with alpha echoes and IV fluids and if you are doing able to do echocardiography during the intra-op phase and a post severe aortic gradient આવે છે then you might just use intravenous short acting interventions. Again, no clear cut many things mentioned in the guidelines, but that could be the possible use and scenario where the hypotension is not that severe and the aortic obstruction is clearly evident on the echocardiography. Hypotension seems to be manageable with the IV fluids and alpha echoes. Then to decrease the aortic obstruction, please go ahead with beta blockade or share. For congenital heart disease, the only thing I want to say is that simple lesions such as a small ASD, VSD, they do not cause any greater risk of MACE during the perioperative period. Any moderate lesions who have been treated, non-complex moderate lesions such as ASD, VSD, PVS, PD, or atrioventricular septal defects, they are intermediate risk. In the complex part, we don't do as of now. Couple of rhythm abnormalities, AS of course, that's the commonest one that we come across. And try to treat the trigger first, sepsis, anemia, or pain, which might be the reason. And patient of new onset AF who are undergoing NCS, perioperative anticoagulation, of course, we are going to do it with short-acting IV agents, is beneficial as compared to the risk of thromboembolism. This is the most important aspect. If you come across a patient in the perioperative phase with AS, please go ahead and do the strict follow-up that patient and evaluate the risk of AF as per the patient's risk profile and try and treat that AF. Again, the same aspects. Same thing, risk versus benefit of per oral antithrombotic agents. Okay. Those who have undergone any electronic device, cardiovascular implants undergone, commonest being PPM and ICDs. If the surgery is a middle-umbilical one and is not likely to cause any electromagnetic interference, you can go ahead and safely do the surgery. If it is an above umbilical surgery, then please consult your cardiologist and get interrogation done. If possible, during the surgery, put the device on non-synchronized mode so that for PPM it does not miss the ventricular pacing and for ICDs it does not cause any unnecessary shock to the patient. So those are the simple things I want to make sure. Below umbilical surgery less likely to cause any electromagnetic interference. You may undergo above umbilical surgery. Please consider modifying the modes of that particular.
બીસીએમમાં છે ને તે કોટરી છે ને below umbilical you can use bipolar cautery. But above umbilical you use unipolar cautery. That is the also recommendation because bipolar cautery interfere with their devices utilization.
Recommendations for oral anticoagulants. Again, we have mentioned it in the study part that patients with CVD or oral anticoagulants are undergoing non-coronary surgery. It has to be a multidisciplinary decision to whether and when to stop the anticoagulants. OA bridging is of course with IV agent is of course beneficial and decreases the risk of thrombotic complications during the perioperative period. During the high-risk surgery, the perioperative bridging is not recommended. So, for the first time I have seen this, that they have given clear-cut risk stratifications for thrombotic clinical conditions. Venous thromboembolism, atrial fibrillation, mechanical valve, any other indications who are in low, moderate and high risk of thromboembolic complications. And as well as they will nicely given where and when to stop which agent for which risk profile during perioperative phase for the ideal balance of thrombotic as well as the bleeding risk complications. And for minimal risk surgeries, usually it is not likely to, you do not have to stop your